Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. This episode continues my discussion of musculoskeletal imaging findings of various forms of arthritis and arthropathies. On this episode, I will focus on high-yield concepts pertaining to lupus, scleroderma, Cppd, and gout. I will make a free downloadable study guide covering the content of this episode available on my website, www.theradiologyreview.com. Please follow at RadRevPodcast on Twitter or Instagram, where I post near daily tips for the physics portions of radiology board examinations. If you have suggestions for episode topics, please email me at theradiologyreview@gmail.com. Without further ado, let's get into the questions and answers for this episode. First question: what are classic musculoskeletal imaging manifestations of lupus? Lupus arthropathy has characteristic features of reducible ulnar subluxations with no erosions. If you see non-erosive subluxation of the thumb, that is termed hitchhiker's thumb, and that can be a musculoskeletal imaging manifestation of lupus. Similar to rheumatoid arthritis, lupus arthropathy can have periarticular osteopenia. Lupus is not classically associated with joint space narrowing. A classic differential consideration for many of these features I have described is rheumatic fever. Potentially the most characteristic musculoskeletal imaging feature of lupus is reducible ulnar deviated subluxations without erosions. Next question: what is the name of the classic radiographic view of the hands that can help you identify lupus arthritis? The answer I am looking for is the Norgard, that is Norgaard, Norgard, or sometimes termed ball catcher view. This is a special X-ray view that can help show the ulnar subluxations at the metacarpophalangeal joints that then would be reduced on the AP or PA views when the hand is in a flat position. For this Norgard or ball catcher view, the hand is in a position as if you are about to catch a ball, with the finger slightly curved. The dorsal aspect of the hand is on the imaging cassette, and the fingers are reaching upwards away from the cassette. The image is taken at a slightly oblique position, and again, classic for lupus would be subluxations that you would see on this Norgard or ball catcher view that are then reduced on your standard AP or PA views. Note also that this same Norgard or ball catcher view also has utility with other forms of arthritis and seems to be a particularly good view for evaluating the presence or absence of joint erosions. With lupus, again, you would expect no erosions. Next, what is Jacob's arthropathy? And in case I did not say that correctly, it is spelled Jaccoud, Jacob's arthropathy. Jacob's arthropathy is a disease of ligamentous laxity in the hand and, similar to lupus, involves non-erosive disease with ulnar deviated reversible subluxations of the 2nd through 5th metacarpophalangeal joints. A classic history for Jacob's arthropathy is rheumatic fever. Remember, I said in the answer to the first question that a classic differential consideration for many of these features is rheumatic fever, and that would be Jacob's arthropathy. If a board's exam question gives you the history of rheumatic fever and shows you radiographs that look similar to lupus, you need to recognize that this is post-rheumatic fever Jacob's arthropathy. However, Jacob's arthropathy is nonspecific and describes the non-erosive subluxations of the metacarpophalangeal joints that are reversible, that can be seen with lupus, psoriatic arthritis, inflammatory bowel disease, and other entities, but importantly, not rheumatoid arthritis, because rheumatoid arthritis should have erosions. To make this perfectly clear, Jacob's arthropathy is not synonymous with post-rheumatic fever state. Nonetheless, rheumatic fever may be the most classic etiology for Jacob's arthropathy, and again, this simply describes the effect of the ligamentous laxity in the hand that can cause non-erosive disease with ulnar deviated reversible subluxations of the 2nd through 5th metacarpophalangeal joints. If you would like to review this again, please rewind or read about this further in the study guide on my website. Next question. What are some basic similarities and differences between lupus arthropathy and rheumatoid arthritis? First of all, subluxations with erosions is most classically associated with rheumatoid arthritis, and subluxation with no erosions is most associated with lupus arthritis. Both can be associated with periarticular osteopenia and osteoporosis. Next question. What are classic musculoskeletal imaging manifestations of scleroderma? Soft tissue calcifications can be prominent with scleroderma, along with features like erosions and or osteolysis of the ribs, mandible, and clavicle. On radiographs, look for soft tissue calcifications and flexion of the digits due to skin retraction. Remember that although the soft tissue calcifications with scleroderma are classic, there are additional erosive and osteolytic features of the ribs, mandible, and clavicle, and you can end up with flexion of the digits due to skin retraction. Next question. What are top differential considerations for osteolysis of the clavicle at the acromioclavicular joint? Differential considerations for osteolysis of the clavicle at the acromioclavicular joint include hyperparathyroidism, rheumatoid arthritis, scleroderma, and post-traumatic causes secondary to repetitive microtrauma. Next question. What are classic musculoskeletal imaging manifestations of gout? Classic imaging findings of gout include so-called punched-out lytic lesions with overhanging edges and soft tissue tophi due to the uric acid crystal deposition around joints. A joint effusion is a common and early sign of gout. Also, characteristic lumpy, bumpy, soft tissue swelling can be seen with gout, or less commonly with something like amyloidosis. A descriptor that I think of that is helpful is that gout has marginal erosions that are oriented away from and not centered at the joint space, with associated asymmetric soft tissue mass or masses, which are the so-called tophi. The joint space is preserved until late in the disease with gout. Extra-articular calcifications can be seen. Gout is more common in the lower extremities than the upper extremities, and most classic would be involvement in males over 40 years of age. Next question. What are classic musculoskeletal imaging manifestations of calcium pyrophosphate deposition disease, which is abbreviated Cppd, and which is also termed pseudo-gout? Classic manifestations of Cppd arthropathy include joint space narrowing, subchondral sclerosis, subchondral cyst formation, and osteophyte formation, very similar to osteoarthritis. However, unlike osteoarthritis, the distribution with Cppd arthropathy may be metacarpophalangeal joint predominant, and most classic would be the second and third metacarpophalangeal joints. As a reminder, osteoarthritis has a more distal predominant distribution in the fingers, with prominent involvement of the distal interphalangeal joints. Cppd arthropathy can also involve the radiocarpal joint and or the patellofemoral joint. If you see what looks like patellofemoral osteoarthritis, but the knee otherwise looks spared, this is highly suggestive of Cppd arthropathy. Also look for classic chondrocalcinosis within the joint space, particularly involving the triangular fibrocartilage in the wrist. The distribution with pseudogout is often bilateral and symmetric. Pseudogout has an association with scapholunate advanced collapse, which is also termed slack wrist, SLAC wrist. To compare and contrast between gout and pseudogout, with gout, expect juxta-articular erosions with overhanging edges and joint space preservation until late in disease. With pseudogout, expect intra-articular erosions with osteoarthritis-like changes. Other classic locations for Cppd include the intervertebral discs and tissue around the odontoid process. If you see imaging showing dens erosions, and that is not dense, but dens, D-E-N-S, if you see dens erosions on board exams, this should make you consider something like Cppd versus rheumatoid arthritis. Got it? Let's move on. True or false? Radiocarpal joint narrowing is more suggestive of Cppd arthropathy than osteoarthritis. The answer here is true. Radiocarpal joint narrowing is more typical for Cppd arthropathy than osteoarthritis, especially on board examinations. Next, true or false? Hemochromatosis can cause similar musculoskeletal manifestations as Cppd arthropathy. The answer here is true. Cppd and hemochromatosis have musculoskeletal manifestations that can look radiographically identical. With hemochromatosis, classic musculoskeletal imaging manifestations include uniform narrowing of the metacarpophalangeal joints in isolation with hook-like osteophytes. If you see this pattern on a radiograph on a board exam, you should consider the possibility of hemochromatosis. To confirm hemochromatosis, I would suggest getting a liver MRI with in and out of phase images and look for the signal increase on the out of phase image compared to the in phase image. Cppd arthropathy usually involves older individuals compared to hemochromatosis. Additional findings of hemochromatosis include low signal that is particularly evident on gradient echo and T2 weighted sequences. The in and out of phase sequence pattern would be opposite of that seen with hepatic steatosis, and to review, with hemochromatosis, you would expect low signal on the in-phase sequence and higher signal on the out-of-phase sequence. Next question. Describe the classic location of erosions for rheumatoid arthritis, osteoarthritis, psoriasis, and lupus. Let's start with lupus. This is a trick question. You do not expect erosions with lupus. With lupus, look for the non-erosive joint subluxations with ulnar deviation. In terms of osteoarthritis and psoriasis, you would expect subarticular erosions most classically. With gout, you would expect juxta-articular erosions in a classic case. And with rheumatoid arthritis, you would expect marginal erosions. I hope that is clear. You can go ahead and review that on your own and look up images to see how each type of erosion can manifest for each of these entities. I hope this and my other episodes on arthritis and various arthropathies have been helpful for you. Thank you for tuning in to this episode. Remember to download the free study guide on this topic available on my website, theradiologyreview.com, if you think that will be helpful for you. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.